going to start things off. Welcome everybody to the J.R. Williams Senior Class of 31 Endowed Lecture Series. Our latest speaker today is going to be Dr. Virginia Bartlett, who is the Assistant Director at the Center for Healthcare Ethics at Cedars-Sinai, who is currently, what shall we say, we're on detail in Baton Rouge, Louisiana. We had hoped to have her in person today, but circumstances of illness prevented that on my part. So we are doing the Zoom thing, hopefully one last time until we can start redoing these in person again in 2023. I'll be introducing the topic in a moment, but what I wanted to do first was to give a little background. First, as I said, I'm David Dukas. I'm the James A. Knight Chair of Humanities and Ethics in Medicine, and I direct the program in Medical Ethics and Human Values here at Tulane University School of Medicine. I also am the Executive Director of our Master of Science program in Bioethics and Medical Humanities. The J.R. Williams Fund is something that was started by J.R. Williams Jr. It was initiated in the fall of 2013 as an endowment supporting lectures on spirituality and health, focusing on the art of creating a compassionate and trusting relationship between the doctor and the patient. And Dr. Williams was a very well-known and beloved internist and oncologist in Selma, Alabama. Having been trained, as you can see, in the 30s, that means in the 40s, 50s, and 60s, unfortunately, a lot of cancer care consisted of palliative care because many of the treatment modalities resulted in having to do hospice, which really was not yet developed in the United States, and palliation. And so for that, he devoted himself toward the compassionate side of medical oncology of how do we at least treat patients in a way in which we ameliorate their suffering and account for the many spiritual things that are happening in the transformation of life. Dr. Williams loved medicine, was the kind of doctor who would do anything for a patient, and an interest in the impact of spirituality on health, particularly on the positive impact of spirituality on the well-being and continued health of those who had suffered the loss of a loved one. I would be remiss if I did not also mention a brief bit about our MS in Bioethics and Medical Humanities. We serve as co-sponsors of this talk with the Williams Family Endowment. We are on the web, very easily searchable at tulane.edu/bioethics, and also on YouTube, Tulane Bioethics. No TikTok videos yet. And we have two tracks. We have a bioethics track focusing on research, teaching, and service through hospital ethics committees, IRBs, and then teaching in all healthcare settings, and then conducting research, both normative and empirical, while also we have a very robust medical humanities track focusing on teaching or research on those aspects of narrative, reflective writing, fine arts, and history as applied to healthcare. Very importantly, we have both a 1 and 2 year MS now, which gives a lot of flexibility for people who are desiring to do a 1-year program, perhaps as a gap year within medical school, but also if they are pre-med and are interested in taking a gap year or have completed a baccalaureate and would like to do a 1-year program in terms of trying to burnish their CV and their transcript to apply to medical school. We also have a very flexible, what I call the slow boat to China route for people who are in faculty development mode, for mid-career professionals where you can take 1 or 2 courses per semester, and that way also earn the MS. We also have an integrated dual degree MD/MS program here at Tulane. It is actually within the elective time that is offered, so you complete it all within 4 years. And then lastly, there is 3 new 12-hour certificates in clinical ethics, research ethics, and medical humanities, which can actually be taken in an overlapping fashion over time so that they are stackable to lead to the MS if that is the desire. If you wish, there's a quick screen posting. So if you take your cell phone and take a photograph of that, it will actually take you to the tulane.edu/bioethics webpage. For contact information, we have both Sofie Affengenden, who is a PhD in philosophy and also serves as the program manager, and Stephen Hansen, who's the director of graduate studies, and emails are listed for both. So what I'd like to do is introduce our speaker. Dr. Virginia Bartlett is the Assistant Director of the Center for Healthcare Ethics and Associate Professor in Biomedical Sciences at the Cedars-Sinai Medical Center, Los Angeles. She serves as a clinical ethics consultant and provides clinical ethics education across the medical center and community, serving on institutional, local, and national boards and task forces, including the Academy for Professionalism in Healthcare when it was first formed back in 2012. Her research and scholarly work focuses on ethics consultation, education, and practice, and how clinical ethics shapes healthcare practice, as well as the experiences of patients and surrogates, clinicians, and institutions. Dr. Bartlett took her Bachelor of Art from Mary Washington College, double majoring in English and religion, then took dual master's degrees, one in theological studies and one in art and religion at Vanderbilt University, before completing her doctorate in philosophy and religion at Vanderbilt in healthcare ethics and moral philosophy. So I'm very pleased to introduce to you Dr. Virginia Bartlett, who will today speak on the ethics of what everybody knows, bringing forward the backstories in clinical encounters. Let me turn off my screen sharing. Welcome, Dr. Bartlett.
Thank you, David. That was a fantastic introduction, and I'm so grateful to be here. Thanks to you and Sophie for getting me organized, and many thanks to the Williams family for sponsoring this lecture. I have so enjoyed being able to participate over the course of the pandemic. It went on Zoom, and I'm honored to be a part of it today. So let me see if I can get my screen up and running.
And for anyone else who's got their microphone on, I'm going to turn mine off, and I'm going to suggest that you all also turn off your microphone by hitting the mute button, please.
Okay, can you all see my opening slide there? Yes?
Yes.
Okay, fantastic. So thank you for having me, and it's nice to see so many faces that I know on this call. It will be both something to raise the challenge, because there are so many brilliant scholars on here, and also folks, excuse me, that I want to kind of get through my talk so that we can hear from each other and have time to learn from and share our own stories. And forgive me as I'm trying to get my screen back up. Okay. Since I have moved, this is my first time doing a lecture in my new home office setup. So thank you for being my guinea pigs on that. First and always, I will go ahead and note that I have no disclosures to reveal. And I want to start today with just a brief roadmap of where I hope that we can go, beginning with a brief overview of narratives and stories, including the backgrounds and backstories and what everybody knows. And I want to talk about our pandemic experiences that add a new layer to the backstories and hence also need attention. And throughout, I'm going to tell some stories myself to illustrate these elements. We listen and pull together and tell stories every day without thinking about it, just automatically. I want us to take some time to think about it. So I'm going to tell you a couple things up front that I hope you'll take away from today. First, and again, this idea that we are always in stories. We are in our own and other people's, but they're often the Reader's Digest or Cliff Notes version, the short and the sweet, the shallow stories, because that's often sufficient for our daily interactions. We generally only pay attention to the fact that we're in stories when there's a plot hole or when there's a cliffhanger, which means that in our day-to-day, we take a lot for granted. We overlook a lot of what everybody knows. Background, scenery, context. But background story elements, many of them unchosen, shape our moral contexts and the ethical possibilities in both our everyday lives and in the dramatic moments. In clinical practice, we can think about and recognize the common complicating elements of stories, histories and locations, personal and institutional and social values, practical constraints and options. And we can do that before the narration grinds to a halt. And then the third thing I want us to acknowledge and be attentive to, as I said, is the disruptions of the pandemic to our stories, because we are still working out languages, meanings, understandings of how 3 years and millions of deaths have shaped our lives, our practices, and our communities. So for the medical students in the room, I have to say up front, I don't have any secret surefire questions to give you, or guarantees that storytelling and story listening will resolve the ethical challenges that you will face in your clinical care. But I do think that they can help us find and make meaning in our clinical encounters. And so I want us to think about that together today. So again, I'm going to go back to this flat assertion. We are always already in stories. They are our stories, other people's. We are involved as main characters, as extras. Sometimes we're the heroes, sometimes we're the villains, sometimes we're the object lessons, sometimes we're the comedic relief. But before we realize it or speak it, and often long after we are gone, whether from the room or from this life, we are part of stories, and they structure our lives without us even realizing it. Stories are how we make sense of our experiences. And we co-create stories in a process of listening and telling. We create them together by sharing. What happened and how? Who was there and why? Sometimes we invite other stories or are invited to share our stories. Often we're just hoping the stories make sense to us and to others. What then? What now? What next? Stories and narratives have become an area of rich scholarship and led to some major cultural shifts in medicine and ethics. And though we're not exploring that fascinating history today and how that's unfolded over the past 30 or 40 years, there are amazing references and resources available, including some amazing references and resources on this call today. So please do follow through with that. Where I want to start is the idea of narrative medicine, narrative ethics, as creating space for patients' voices to be heard, and for hearing patient stories as authentic, as essential for providing good care, ethical care, patient-centered or patient-family-centered care. We take that for granted these days because of all of that work in narrative medicine, in narrative ethics. But even though nobody is really disputing the fact that stories are helpful in clinical care, we all each face questions of how we're going to elicit patient stories and how we practically integrate them into care plans. Maybe most particularly, how we make time and space and how we learn to hear what all matters in those stories. Because sometimes we're not the best of narrators of our own experiences or stories, either because we don't really have access to our full range of thoughts, or we don't have information. Sometimes we don't want to know. And so in either case, we actually need other people to tell our own tales. And Secondly, our stories don't take place in a vacuum. They occur in contexts which form our backgrounds, which shape what we see, what we hear, what we do. Yet a lot of those backgrounds are often out of our control and beyond our choice. In a clinical setting, we are always structured by and oriented towards stories, even though, again, perhaps without recognizing it in our daily practice. We collect stories and create them, filling in bits and pieces together, revising in real time. Think about your clinical encounters. We start by gathering a patient's history. Depending upon your role, you'll ask for, listen for, and document different elements of that history. So even in the very first encounter with our patient, the very first day, we have multiple stories at play. The emergency medicine or triage nursing notes, the admitting physician's H&P, the specialist or consultant's initial consult. And then there's the social work notes or the case management notes, the chaplains, the patient financial advisor, the biological, psychosocial, economic, religious. All of these are part of the patient's story in each encounter, but they're often in the background. They are noted by routine rather than noticed by intention. Now, when things are going well, we tend to come up with a short story of our time together, clinicians and patients and families, where we generally agree on what's happening. We have a sense of what makes sense. And we really only get and give these kind of surface level, practical, bare bones stories to each other and about each other, even in the most detailed H&P. And that's okay. Not every story has to be an epic, even if it's an epic. Because whether the patients stay or our interaction with them is long or short, we are never going to know the whole story, and we shouldn't aspire to. We are large, we contain multitudes. And we don't need to know the whole story to take care of patients. We need to know enough of the stories and backstories to care for this patient in this moment. The tricky part is that enough will be different and unique to each and every encounter. To make plans for patients, we often talk about needing to know their personhood and their pathophysiology. We discover their goals and values and preferences and what's going on with the body, what the options are. And that's both not a whole lot to learn, and it's a lot. It takes time, effort, and energy, and yet it is only a fragment of their lives. It's enough to create a plan about what makes sense, what we expect to happen next. This is how we bridge from that initial chapter of an H&P to the final chapter of a discharge summary. We elicit goals and values, and then we don't even realize that when we're doing that, we're creating a story by pulling together and editing and constructing and weaving the strands of information and data, the unacknowledged background, into something coherent. We do it with just enough depth and just enough breadth for everyone to move on together. We don't necessarily need or ask for deep personal knowledge of people's religious and cultural values, or specifics about insurance, or details about family dynamics. Because most of the time, we don't actually have to think too hard about that. The bare bones are okay. It's enough, it's fine, really. Except when it's not, and it's not always. So we have to be aware of those background elements as potentially influential and meaningful. And we have to remember that our Cliffs Notes or our Spark Notes version are crib sheets. They're a shorthand. They may be necessary for us, but they're not always sufficient. We have to be paying enough attention as we're reading a situation, skimming really, to recognize that something isn't right, that something's going on that we don't understand, and when something doesn't fit, and so the story doesn't make sense. These are actually the moments when we recognize that we are in a story or a set of stories, because the action has come to a halt. We need to understand or learn something to keep the story going. We've reached the choice page on the Choose Your Own Adventure, but we remember that it's not just one choice to make, or maybe even our choice to make. We aren't reading alone, and those around us, patients, family, clinical colleagues, all seem to have started at different places to get to this moment. So what now? This is where we recognize clinical experiences as experiences in story, and recognizing those as experiences of storytelling is helpful, I think. So I'm going to shift to some of what storytelling gives and demands of us. If we think about clinical stories as creating meaning and making sense, we have a lot more room to maneuver. and possibilities for understanding than if we think about clinical experiences as problems or puzzles to solve with an answer or a solution. Stories give us a starting point to ask questions and to acknowledge that our shared understanding of what's happening, our shared history of what got everybody to this moment, our shared expectations of what's next may not actually be shared. And so stories demand a humility and a curiosity, an intentional care for the stories and about understanding. Maybe we're missing information about the patient. Either it's just not available or the situation has changed, so what we had before is now inadequate and we can't flesh out the story enough. Maybe there are incongruent or contradictory storylines. Maybe the narrators and characters are in dispute about what's really going on or how to make sense of the information, excuse me, and details available. Or maybe there's assumptions about the other narrators and characters themselves that are coming to light, framed as concerns about their beliefs or motivations, their honesty or their comprehension, their reliability or their trustworthiness. These story elements emerge in the context of everyday clinical encounters that are, wherever we're working, really similar across patient encounters. And yet they are crucially unique and complex every time. The practical matters, the daily details, the local issues, the stuff that everybody knows and takes for granted are the things that are so routine that we don't even look at them most of the time. Which means that sometimes we can't even see them until some aspect matters deeply and is problematic or concerning, and which can only become unclear in the unfolding clinical encounter. Or, as I hope to emphasize today, unless we make it part of our practice to listen for them, to be attuned to and to attend to them. And so here's naming some of the deep backgrounds that are often taken for granted elements because they are so far into our practice, into the ways that we engage, that we don't even recognize them. But these are also and can become a source and a wellspring for reflection and engagement beyond just the day-to-day, beyond what everybody knows. Everybody knows there's multiple sources of divergent values, but we can actually focus on and think about those. Everybody knows that trust is an issue in healthcare, but we can actually focus on and think about how those emerge in particular cases, in particular stories that we hear. These are the elements of clinical contexts and facets of clinical encounters that we actually need to choose to recognize and engage. Because no matter how obvious, and sometimes because they are so taken for granted, no matter how obvious they seem, engagement with what everybody knows requires intention and some practical approaches to support our curiosity and our humility. Like recognizing that simple and quick answers may be what we want, but they aren't what we need. Or being willing to have open and clear communication with other stakeholders. That sounds so simple and straightforward, and yet we all know how difficult that is and how much time and space that requires. We have to acknowledge that we can't know in advance what is at stake in any particular question or story, no matter how similar to a previous case or situation, or even how well we think we know the other stakeholders. We form relationships within our clinical communities, but sometimes we get very surprised by how people understand this story as it's unfolding. We have to work by being open to learning in real time, listening attentively and carefully. And by that, I mean listening with care to the elements of relationships and moral experiences in actual decision-making. And finally, we have to commit to learning what's at stake beyond just what we typically think of what a patient wants or what a patient's preferences may be. Family, community, other clinicians also have values, goals, and practices that undergird their actions and their choices that are part of the backstories that we have to think about. Now, as mentioned at the beginning of our time, aside from the recognition that we live and work in stories always, the idea of these practical approaches kind of falls under two big practice points that, again, I hope you take home from today. That idea that we have to recognize and remember the background story elements that shape moral contexts and possibilities. We have to be attuned to them and listen to them and respond to them when we recognize their influence, even if our patients and colleagues don't. Even if we think, of course, everybody knows that, sometimes they don't. And again, I want to, and we'll get to the idea of the complexity and the weight of the pandemic's influences on our clinical encounters. Because our new normal of 3 years and counting of abnormal means that we have to be listening for clues, mentions, references to how people are experiencing and processing, even though we're not even sure at this point what those kind of clues, what that language would look for and how to respond. So part of our task is to listen carefully, tell our stories together, and build those stories as a community. Now, for those of you who are students, this may or may not be new. I don't presume to know how much clinical exposure you've had. In our discussions, maybe you can share some of the kinds of stories that you've encountered, whether weird or routine or off the wall, especially in your pandemic stories. For those of you who have been in practice in clinical contexts and healthcare settings, I hope this can be a reminder that everything old is new again. And see this conversation today as an invitation to share what you listen for and attend to in your everyday and extraordinary clinical encounters. So I want this to be an invitation to all of us to consider just how complex clinical encounters in healthcare may be, and to reclaim some of our astonishment and curiosity about stories, our own and each other's, our wonderment about protagonists and supporting characters, scenery and backstory. So I'm going to tell 2 stories to begin with to kind of illustrate how some of the backstories can come out. And I'll first introduce Mrs. Graham. She's somewhere in her 60s, came to us by ambulance, found out on a sidewalk with her wallet, keys, and a Trader Joe's bag of peanut butter, bread, and coffee. She was resuscitated, intubated, and found to have a massive intracranial hemorrhage in the thalamic region. She had an emergent EVD placed to manage the swelling and the increasing hydrocephalus, and she spent 10 days or so in the ICU with our intrepid social worker, calling missing persons, tracking down insurance information via social security number, and Googling the address on the expired driver's license, coming up with an apartment building, but no number. No family or friends were identified, which meant that Mrs. Graham met the criteria for an unrepresented patient. The ethics consultation came in for an SER, a special ethics review, which is our policy outline process for decision-making around major invasive interventions or withholding and withdrawal. The ICU physicians asked for this SER to discuss placement of a trach and peg, as after 10 days, Mrs. Graham was still in the thick of neurologic injury, and any recovery was expected to take weeks to months. She wasn't looking at a full recovery, given the extent of her brain bleed, but the team expected to be able to wean the EVD, and then she'd be stable for discharge to a skilled nursing facility to allow tincture of time to do what it would. The story, although tragic, seemed straightforward enough. But then we fast forward another few days. Mrs. Graham's team had been unable to wean her EVD without causing massive spikes in her intracranial pressures, and the neurosurgeons are concerned this is a sign of greater damage than previously seen, which meant her chances to them of recovery were far lower. They now read Mrs. Graham's story very differently than the ICU team had. The neurosurgeons worried about the risks and burdens of putting in not just a peg for nutrition and a trach for airway protection, but now a VP shunt to manage her brain's overproduction of cerebral spinal fluid. The neurosurgeon expressed angst about doing this just one more procedure, because it wouldn't be just one more. It would lead to many more. Shunt revisions, infections from aspiration, surgeries for decubitus ulcers if Mrs. Graham stayed bedbound. They worried about neglect and a facility without family or friends to advocate for her post-hospitalization. And they worried she would recover just enough to experience pain and her debilitation, but not enough to be able to express her needs or distress, or to participate in any therapies aimed at recovery. They asked, how could we do this to her? How could we sentence her to a future, to this kind of story, to this kind of suffering? In our SER conversation, we made space and took time for the clinicians to share their stories of taking care of Mrs. Graham over the past 2 weeks, and to share their stories, imagined for her, based on their experiences and professional judgment, about what they thought her story would look like, depending upon the treatments chosen. They looked at data, another kind of story. They used ICH prognosis calculators, and each came up with the same numbers and percentages, but they found different meanings in the clinical data and studies available. They prognosticated, they imagined, they told different stories about the futures and outcomes for Ms. Graham. And they raised concerns about quality of care in the nursing home, fear of liability, and their worry about inflicting harm via suffering and an extended dying or inflicting harm by withdrawal and foreshortening life, for doing too much and for not doing enough. And I share this story because it highlights some of those background story elements, some story elements that weren't present in the ICU team's first draft of the story, and ones that are so backgrounded we have to actually pause to see them, to hear them as they come out in conversation. Like again, we normally think of determining what fits for patients based on their goals, values, and preferences and their prognosis. But for Mrs. Graham, we had no access to those, and we had rather significant uncertainty about her pathophysiology and prognosis. And you can hear some of the other elements, like the different professional commitments, power dynamics, and hierarchies of physicians versus surgeons. These are two different teams with two different orientations, approaches, and power within the institution, who are having different understandings of what's happening. Background elements like the fear of lawsuit, different errors for not doing enough or for doing too much. Other issues that are, again, below the surface, but affecting patients' care, affecting clinicians' decisions. Concerns about the social factors. The patients without advocates in the community don't do as well. Or social values, prioritizing cognition and communication and disvaluing debility and dependence. Or the question of justice and resource allocation for a patient with a poor prognosis for recovery at best. And the economic concerns. What kind of nursing facility will she wind up in? Because that can also affect her prognosis. Or the questions of time and certainty. How long does certainty take? How quickly can someone move out of the ICU? How long must they stay in the hospital? How soon until we can make a decision? Certainty. What if we're wrong? How will we know? When will we know? What if we don't know? Swirling around these conversations, we also have to be aware of and attend to the background elements that are not even explicitly named, like concerns about technology, reliance on technology and also failures, about the 30-day returns and reimbursement that worry our case managers, about the possibility of having to approach the courts for guardianship. All of these are elements in the background, unchosen, and yet they shape the story in profound ways. These are things that everybody knows because they're part of the warp and the woof of the clinical story. And they create challenges for Mrs. Graham and the clinical team, but they're so taken for granted that they have to be explicitly recognized and raised, acknowledged, and invited into the discussion about the story's directions and meanings. None of this is automatic. Listening and telling is not first draft storytelling. This is a collaborative process of visions and revisions. Here's another story, different patient, a different ICU team who called about Mrs. Wilcox, or more specifically, her son, who, in the words of the resident, weirded everybody out. The resident went on to explain, he's telling us she's a Jehovah's Witness, which means she won't accept blood products. But he then told the night nurse that she would accept blood if he donated it. If it was his blood, then that would be okay, not any other blood. Her hemoglobin is dropping and we want to transfuse, but he's saying no because he hasn't gone to the donation center yet. And he told us we're not to talk to any more family members. And he's the surrogate. It feels wrong. Can we remove him as surrogate? So there's a lot of somethings actually that didn't make sense in this story. So as is my practice, I went to the chart and looked to see what I could find, especially to the social work notes, because again, for the residents, for the students, practical advice, if there is a story, it is in the social work notes. They are your friends, I promise you. And for this gentleman, for his mother, the story was there. Not from this admission, not even from the last admission, but it's in there. Mrs. Wilcox is a Jehovah's Witness and has discussed and documented that she will accept blood transfusions if donated from her children. Since their blood contains her blood, it's enough to be acceptable, close enough. Okay, well, that's a variation on the usual, but there's always variation in how religious tenets are worked out in individuals' lived faith. Okay, reading further. She has one son and two daughters, one of whom has mental health issues and addiction issues, and one of whom left the faith and hence the family years ago. The first daughter reportedly tries to take advantage of mom financially, quote, only calls looking for money, and the second hasn't been heard from in years. So the don't call anyone has some teeth to it. It was documented from the patient's conversations with social workers on family background. And so here's the thing about Mrs. Wilcox's backstories. They were fairly easy to find and discover, and to share with the clinical team. The son, as strange as he may be on presentation, appears to be the appropriate surrogate. But this story again highlights how many other assumptions and background elements are at play that shape the unfolding action. Like background assumptions about how families work or should work. Who should take care of an aging parent? Why is he keeping his sisters out of the loop? Is there something inappropriate about his relations with his mom? This seems weird. Or religion, how Mrs. Wilcox exemplifies the kinds of complexities that emerge when religious traditions with broad beliefs are practiced by humans in their very unique specificity, and how uncomfortable we are with variations on themes. It illustrates questions around trust, how fragile and fleeting trust is. In our regular daily lives and personal interactions, we speak differently to different people all the time. Yet somehow in a clinical setting, if a surrogate tells one part of the story to a physician and a different part of the story to a nurse, there is a leap to distrust, deception, duplicity. Something isn't right. Or think about the challenges of teamwork, whether clinicians in one discipline even know what their colleagues in another do, or how they're supposed to work together. The information needed to resolve the ethics issue was available in a set of notes not too far back in time, not too distant from the patient's current unfolding story. And whether from ignorance or overload, the team didn't look for other storylines beyond the one that was immediately available. They only looked at the cliff notes and they thought that was enough. The point here is all these background elements come out from underneath and in the middle of the real ethics question. They're important parts of a backstory, which present in each clinical encounter, but they aren't always obviously the important issue, which means we have to remember that they are there. We have to get into the practice of listening for and being aware of the values about family, religion, teamwork, our own assumptions, trust, hierarchy, economics, so that when these emerge in indirect conversation, we can decide when and how to pursue them. To quote my teenager, we have to see if we're on a side quest or the main journey. We won't know until or if and when they come up in the clinical encounter, if and when we listen for and talk about these underlying values and themes. Now, neither of the stories that I told could move forward until more information was gathered or until assumptions were clarified and contradictions worked out. The gaps in different perspectives are for sure moral elements that need to be addressed. And so in these two situations, developing and creating shared stories required understanding of more than just personhood and pathophysiology. They required insight and participation, information and engagement from multiple sources, multiple clinicians, in order to create the conditions for and the possibility of meanings beyond outcomes. Now, I want to acknowledge again, engaging stories still might not be enough. We may ask and answer, we may listen and tell, we may make and take time in dialogue, and we still may remain stuck in unsatisfactory outcomes and disjointed stories, which then become part of our practice as cases that haunt and what ifs that make us wonder when we're going to see the next one. But we don't always get stuck, and we won't know until we explore. And one of the things that I've noticed over recent history is that the kind of insight and participation, the kind of exploration and discovery that's necessary for creating these stories together is getting harder to find. And there's at least one fairly glaring reason for that. Our clinical pictures and our experiences and stories have changed and are still changing, thanks to the unprecedented COVID-19 pandemic, which adds new elements of different facts and facets to our clinical experiences and moral concerns. And so I want to spend a moment thinking about the still unfolding influence of COVID-19 on our stories, not because any of us are unaware that COVID complicated everything. After all, we've been living it. It's our day jobs, and we are community members and have families, and sometimes have been patients ourselves. But rather, as healthcare professionals, our individual experiences and frames of references, along with the broader community experiences of our patients and their families, are important to have in mind. And they are not yet well articulated or widely shared within, let alone across communities. So I want to do a quick review because, again, I think these are important things for us to hold on to. And starting with the acknowledgement explicitly that in the middle of this pandemic, in the worst of it, Healthcare workers, including those studying and training in medicine, nursing, and other allied health professionals, continued to show up. They worked through holding on with fierce determination, with fear, with professionalism and panic, helping others and trying to stay healthy. And we've done so while facing at the same time staggering levels of burnout and recently a growing exodus from the various health professions. We found ourselves facing a novel virus that tested scientific, governmental, healthcare, economic, political, and community norms on every level of daily life. And they continue to evolve and mutate as we enter the third winter of pandemic surges, even as our prevention and our treatment strategies evolve to meet it, even as our coping strategies have had to evolve to meet it. And our strategies and coping have responded as the stark questions that we encounter at the bedside and in the boardroom across our dining room tables shift and sharpen focus about resource allocation for ventilators and vaccines at the beginning, vaccine hesitance and mandates in the middle, and now worries about vaccine booster uptake and how slow that's going. The pandemic highlights new narratives around health disparities and social injustice, not new problems, but individual and community stories that are rendered even more grotesque and challenging in the uncertainty of the first 9 months of the COVID pandemic, which was unfolding amid deep and disruptive political and social upheaval that continued in 2021 without the return to normal that we had been promised, and thanks to the rapid dominance of Delta, just continued holding steady with uncertainty and political upheaval in 2022 and with Omicron, and now we're barreling towards 2023 with triple demics and significant pandemic fatigue. But as healthcare workers, we continue responding, even with the current statistics of over 1 million lives lost in this country and over 6.6 million worldwide. None of this is new, I know. We've all lived and are living through the pandemic when we're not actively blocking ourselves from thinking about it. And no one goes into healthcare for the easy money. And I apologize for the medical students if you were misled up until this point. But seriously, why rehash history? Why does this matter? It matters because in the post-pandemic world, even if we are not quite there yet, the pandemic storylines introduced different elements that we need to pay attention to in healthcare. As providers, our experiences are morally relevant and can be ethically significant in ways that demand attention, even and especially while in the pandemic, demands on us have increased and our bandwidth has decreased. Many of us have been pivoting and shifting, hearing praise for our resilience, and trying to adjust through what the futurist and artist Gerd Leonhardt called the Corona coaster. We're struggling to care for ourselves, our families, our peers, and our patients when our surge capacity, the ability to come through in the clutch and to respond and survive stressful circumstances, is frankly tapped out. We call it burnout in our various clinical disciplines, and like so many things, it's not a new problem. It predates the pandemic, but the sheer breadth and numbers of clinicians reporting burnout and moral fatigue powerfully influences our interactions with patients and families, with each other, and in ways that make already complex and challenging moments more frequent and more wrenching. So while our surge capacity helps us keep moving, if we don't stop and look at it every now and then, we're going to find ourselves missing some of these important stories and subtexts, overlooking crisis-induced shifts in practice that need attention as they become part of the business as usual of backstories, of everybody knows, and hence that people forget to think about. So I know we're moving towards time, David, and I do want to have some time to have conversation, but I'm going to go through my last story quickly, I hope, because I think that it illustrates, again, some of these newer elements from the pandemic that are becoming part of our backstories and so require that we think about them again. I got a call from an outpatient physician who no longer admitted directly to the hospital, but used one of our hospitalist services. He was worried about his patient and his patient's wife. Mr. Simpson had been admitted for his first bout with COVID, and keep in mind, it's like the third COVID summer. He came from a rehab facility where he'd been for 3 weeks after he'd been discharged from our hospital from complications from his longstanding cardiovascular disease. He hadn't been home in months. He was in his 80s and he was on the floor in the main hospital, not even in the ICU, but isolated and confused. And the doctor was worried because the wife couldn't visit, since Mr. Simpson was COVID positive, and was told by the hospitalist that unless he was dying and on comfort-only measures, she couldn't come at all, and then only for 2 hours. The hospital explained that the policy was to protect Mrs. Simpson from her husband's infection and to protect others from any infection she might carry. And the primary doctor was distraught, saying this was unethical to him that a policy could be so rigid and inhumane. So what is it in this that makes it ethically or morally challenging other than just sad? What does this show us? Well, sometimes what everybody knows isn't so. And sometimes there's parts that only a few people know, little things that have a profound difference for the stories that unfold. Like listening to the primary doctor tell me about this patient of his, that the couple had been together for over 50 years, late in life sweethearts, both near 40 when they found each other and inseparable ever since. They'd gotten married 25 years ago under duress when he'd had his first major hospitalization for cardiac issues and nearly died. They'd been together for decades at that point, but she didn't believe in the patriarchal institution of marriage. But when he got so sick, they thought she couldn't be his surrogate if they weren't married, because she might not be able to take care of him and help with medical decisions. So they had a rabbi perform the ceremony at bedside. She bought a secondhand bridal gown at the Goodwill down the street and grabbed a get well bouquet from the nurse's station. No joke. And she slow marched herself from the ICU door to his bedside, singing "Here Comes the Bride" in a dramatic voice. He survived the cardiac surgeries and she survived being officially married, the primary doctor told me with a laugh. And he sighed, and I could hear the smile over the phone as he said, they are each other's lives. Okay, second bit of backstory. The primary was frustrated that the hospitalist was holding so tightly to a policy that didn't seem to make sense. Mrs. Simpson had recently recovered from COVID, so wasn't at risk at the moment. Unlike many COVID situations, oh, and by the way, she had given Mr. Simpson his COVID. So unlike many COVID situations, the timeline and exposure for infectiousness were clear. Which is relevant for the third point. The hospitalist had been the one to convey to the visitor restrictions to the wife and the primary. And even though Mr. Simpson was sick as a dog, he wasn't dying. Rules were rules, and the policy was longstanding. She was holding to this. Except the fourth bit of backstory, the tired and stressed hospitalist was wrong. They didn't know that the hospital had recently changed its COVID visitation policy, allowing, even in COVID cases, with approval from nursing unit leaders. And what I learned from the primary doctor, what he knew that the hospitalist did, was that Mrs. Simpson was almost 2 weeks out from her symptom onset and was about as safe to come in as anybody else. So here's the thing. This was another ethics consultation that was rooted in background elements that grew into profound moral concerns, explicitly pandemic induced, like the default to pandemic protocols and challenges of remaining up to date on evolving hospital policies and practices, compounded by the significant clinician burnout. There was a young hospitalist who had finished residency and started practice in the pandemic, and so knew only crisis, had no normal to refer to and rely on in their practice, no remembrance of non-crisis moments. The consult question was about visitation, but the ethical issues were about the background elements. The moral work, the listening and telling, included sharing this couple's story with nursing leadership, with the ICU doctors, so that when he transferred there 3 days later, knowing they were just as burned out and overwhelmed as the hospitalist, there was hope that they could find space and time to care, not just to treat. As the ICU attending told me later on that week, for their team, knowing the Simpsons romance did help the residents and fellows, as they made sure when he was deteriorating that Mrs. Simpson was at bedside, that they were able to build a communal story as he died, his wife, his primary doctor, and his ICU team, about what happened between the H&P and the death note, including those stories from before he got admitted, and including clinical stories that Mrs. Simpson could carry with her as she buried the love of her life. Knowing the backstories doesn't guarantee a happy ending to the current narrative. Mr. Simpson still died, but learning and sharing his stories created new possibilities for going on, which his wife, his primary doctor, his hospitalist, and his ICU team all needed to do. And their story gave me, and I hope gives you, a reminder that the moral encounters in healthcare are not solely about outcomes, but about how we care for and about each other, which includes how we make meaning and build understandings together, which involves going back, below, behind the initial story we hear. And that's something that may be even more crucial in our late post-pandemic practices. So I'm going to wrap up with out of ethics talk. Everybody's waiting for the moral of the story. What's the takeaway? How do we get this? How does awareness and attention to background and backstories get incorporated into clinical practice? The short answer is both the easy one and the hard one. gets incorporated by doing, by orientation and practice, by deciding that you want to learn about your patient's stories and that you want to pay attention to your colleagues and your own stories as you take care of patients together. And it takes practice without making perfect. You practice by listening, knowing you're going to miss some things and still being open to learning, to asking, to taking and making time, even when you have none. My favorite and least favorite Zen story is about the monk who asked the master how long he should meditate each day. And the master thought for a long time before replying, 20 minutes each day. Unless you're busy, then you must meditate for an hour. There will always be tasks that need to be done, and there is never enough time to have the long and full conversations with any of your patients, let alone all of them. But you can still have fulfilling and fruitful conversations. You can still listen and talk, remember and recognize that you are in stories with them, and think about what you need to know to make sense and meaning together. And I'm going to wrap up here because we do have some time for conversation, I hope. Is that about right? We've got about 10 minutes left, David?
Yes, we do.
Okay. I could keep going, but I want to actually, again, this is what I want to end with, is the idea that this is both nothing new and also new every single time. This is part of regular practice, and it is also a stepping out of our everyday. And again, I think that if that is what your residents, your students can take out of this, is that there are backstories. They help us understand what's at stake. They help us learn how to take care of our patients and take care of each other. Then that is the first step, and also the always and only step of clinical care. So
All right.
I'm interested to hear people's questions and comments, especially around their pandemic stories and how that has affected their clinical care.
So why don't we have you stop sharing?
Yep.
Then what we'll do is ask people to raise their hands so that I can call on them. If somebody has a question, they can do that. Let's see, I've got 2 with raised hands. Where are they? Well, okay. Renee, if you could please go ahead and ask your question, sir. You'll have to unmute yourself.
Yeah, thank you so much, Virginia. Great talk. One of the things that struck me is I really appreciated the intention, just saying when you approach that history or to go and find the deeper backstory, doing that with intention. I agree with you 100%. Not COVID specific, but for me, I deal with limb salvage and deal with amputation and patient autonomy leading away from loss of limb. I always like to ask about where does your fear about this come from? That open-ended question of asking about the fear. A lot of the times they relate seeing similar healthcare situations play out with family members or loved ones, and they feel like they're repeating that. And if you can just, in my experience, if you can just affirm that that is scary and that these disease processes a lot within our genetics lead us down similar paths, there's a trust built within that relationship. They hear you, they feel like you understand them. And again, it just goes back to asking, where does that fear come from? Where does that hesitancy to trust what your providers are recommending to you? But again, doing that with intention and really being there to find out that information, I think makes all the difference. Thank you so much for your talk. It was very helpful.
Thank you. And I think that's 100% right. And one of the things that, again, I hear from our residents and fellows, if I don't have time for that, or how am I supposed, what if I go in and talk and I get sucked down the rabbit hole of 4 generations of family history? It's like, well, 2 things. One, you will actually find out more than you imagine in a much shorter time than you imagine. And 2, that may actually be the history that you need to know. One of the things I apologize to other teachers and clinical mentors if this is not an okay thing to say, but one of the things I tell our interns to do is tell your patients on rounds, you're going to come over and talk to them in the afternoon. Just, you don't have a whole lot of time. You're an intern, you're slammed, you've only got 5 minutes, but you're going to go over and you just want to talk to them about what they're doing, what they're going through. It's not a clinical call, it's a social call. And when you go in, you tell them, I've only got 5 minutes, but tell me a little bit about yourself. Tell me about what got you here. I tell them if they want to use the, the dating trick of having your senior like page you in 7 minutes, so that you have an exit if you need to do that. But the idea of to take and to make that time to take seriously people's understanding of their own experience is so vital to helping them get through it and to helping us continue to provide care in challenging circumstances.
Dick, you have a question.
Yeah.
Culbertson.
Thank you very much, Dr. Bartlett. As a former CEO of a hospital down the street from you in Los Angeles, Kaiser Permanente Sunset, I'm concerned in my own experience that I see what I call a bureaucratic imperative, which is in the clinical world largely driven by the electronic health record phenomena. We know from research studies done at UCSF that somewhere between 70 and 80% of all content of an EHR is cut and paste. And the advantage of that, of course, is you don't have to listen to the patient. I mean, you just pull whatever somebody advisedly or misadvisedly put into the narrative. And I cite Atul Gawande's writings, particularly on this count. How do you counteract that from an ethical point of view, that dismissal basically of listening to the patient?
That is a great question, and one that we encounter and talk with our especially our younger colleagues who, again, only grew up with an electronic medical record and so don't have that experience of sitting down and writing with somebody or taking notes in that way. And one of the things that we've actually discovered from some of our colleagues is that, again, the medical record, the chart, it doesn't hold the information that's got that kind of substance to it. That gets in, like, there's a sticky notes program or like a clinical handoff that changes every day. And so it's not part of the permanent record. And it's maybe only among certain teams who have access to it. And so, whereas at one point, you could maybe go to the record to find those kind of deeper substantive stories, they get harder and harder to find now. So 2 things on that. One, I find that our social work colleagues still tend to write the kinds of narratives that tell you a story, that tell you the background and the quirky facts and the things that keep our patients being people. So I always advise and recommend that our colleagues go there when they are concerned or confused. The second is that just like there's the technological imperative that pushes us for surgery and intervention, and there's this bureaucratic one of let's keep it streamlined and let's, quick and dirty and as fast as we can. In some ways, it actually still, as it always has, comes down to individual clinician responsibility, which is, again, that at the end, like, how do we do this? By deciding to do it, by deciding we're going to take the time and make the space. We don't have it. We will never have it. There will always be the bureaucratic things that pile up and that take our time. So it has to be and become part of our practice that, no, I am going to spend X amount of time with these patients. And part of that is your judgment. There might be one that only needs 3 minutes. There's one that might need 30. And so you have to be willing to be flexible in your own kind of responsibility.
My own thoughts about this is that EMR has been a disservice to us in a variety of ways, both clinically and clinical ethics consultation. It reminds me of Archie Bunker, going back 40 years, of him beckoning to his wife, Edith, get to the point. He would try to excise all of the extraneous stuff and just get down to what he wanted to know. And clinical ethics has developed fairly regimented methods of documenting case consultation. But the problem is they omit the essence of stories such that there's no narrative, and there needs to be that contextual understanding of the backstory. So I agree with you. Social workers often have that, but we shouldn't be turfing to social workers the responsibility of listening to the stories. So
Yeah,
how can
and
we
we find ourselves also being, as the clinical ethics consultants, a lot of times we are the continuity over, especially for a
right?
complicated situation.
So
Yeah,
how can
so
we
I
get
don't know
that
the solution
essential
except for,
component, incorporated so that we're not always at the last moment, like Paul Harvey saying, now you know the rest of the story, because we decided to discuss with the elderly couple, oh, yes, they have this long history of 50 years, and
right.
this is why we need to re-examine COVID isolation.
We have a colleague at Cedars, he's probably one of the best clinical instructors I've ever worked with, and he always tells the residents, your patient shouldn't have to be lucky enough to be dying for you to ask about their goals, values, and preferences. That should be the first thing that you find out, not the last thing you ask before you change their code status. And it's, again, so simple, and yet it actually requires that kind of intentional practice of, this is something that's valuable to me. It's valuable to my patients.
Okay, and we have one last quick question from Larry Driver, because we're actually a little over right now. Go ahead, sir.
Hopefully you can hear me.
Yeah.
I have a technical challenge here, but I do pain management and palliative care for cancer patients here at MD Anderson in Houston. And, in the past 25 years, I regret that I have missed a lot of wonderful stories, I'm sure. I just right now have started taking an online course from the University of Toronto in narrative medicine, hoping to learn more about how to do this and apply this in my day-to-day practice and teach my fellows and residents. So thank you for your wonderful talk, and keep up your great work.
Thank you.
And I think we need to bring this to a close because we're a little over time now. I believe firmly that we should all owe a great deal of applause to our speaker, Virginia Bartlett.
Well, thank you all so much again, David and Sophie. Thank you for arranging this, and thank you again to the Williams family. I've enjoyed getting to talk with you all today.
Thank you. Take care.